This is the second of two videos in the vaginal mesh series. Since the first video, we've had a very good growing season in Fulham, and we've also had the report of the review group led by Baroness Cumberledge into vaginal mesh, primidos, and sodium valproate. My interest in these matters is I'm an obstetrician and gynecologist. I used to do urogynecology up till about 2005. After that, I've done pelvic pain, both as a research and a clinical interest. And in this respect, I arranged something called the Bristol Anatomy course, which we held once or twice a year between 2001 and 2012, which was specifically for urogynecologists. And we had 20 along at a time to have a dialogue about all the anatomy, the different operations, the complications. It was pretty clear by 2004 to 2005 that there were serious and significant problems with vaginal mesh, particularly in rectal prolapse, but also they were beginning to emerge in urinary incontinence. And what I'm going to do in this video is try and fill in some of the gaps, because there's been a central mismatch in the review group's evidence between what the suffering of the women and the evidence that the review group has received. And this video is going to try and fill in some of those gaps. So this is the review title, First Do No Harm, and the recommendations. I thought the Patient Safety Commissioner was an interesting recommendation, but I think it would need at least half a dozen regulators to be removed in the NHS to create the space for this. They clearly identified the problems of the MHRA, which have been there for decades. And they recognized that most of these tasks were going to rely on third parties to implement them. And that required a separate layer of bureaucracy, which was not altogether ideal. I'm going to discuss the 5 mesh pain syndromes very briefly. 1, 2, and 4 are well known. Number 3 is a new one that I've only heard about from third parties. I haven't managed any cases or anything like that. But it seems to me clear that some types of obturator mesh, particularly in the third generation ones, the limbs retract into the external genitalia shortly after the insertion, create a painful foreign body reaction. This applies to one of the third generation meshes that I'm aware of. There may well be other syndromes associated with other meshes. And then number 5 is the vaginal neuropathic pain, which is the real beast in this set of pain syndromes. This one starts about 3 years after surgery, and it's associated with straining during defecation, such that when you put the mesh in the urethra, when a woman strains down, she strains down against a fixed, immovable sling, which transforms from being a support into a cheese wire. And that's what's causing most of the very serious complications. And gynecology has lost the pelvic nerves in the 1945 era. And this shows on the left the gross morphology of the pelvic nerves, which we demonstrated on the Bristol Anatomy course. Every single time, every course, we went through this as a highlight of the proceedings, because it's clearly the injuries to these that are the source of most of gynecology. Not all, but most. I'll come back to that in a minute. Before 1945, after 1945, we only had these representations of the nerves to look at. And this is a particularly good preparation of them. But for the most part, we haven't seen the gross morphology of either the pelvic, the cardiac, or the celiac autonomic plexi. And it's injuries to these nerves around the body that may be the source of many chronic diseases. I'm not just talking about obstetrics and gynecology, but things like diverticulosis, Crohn's disease, ulcerative colitis, hypertension, heart disease, also asthma, all sorts of other diseases, which are likely to be the source, that injuries to autonomic nerves are likely to be the source for. And in terms of mesh, what happens in the cheese wiring effect is that you cut through the nerve bundles regenerate in this chaotic form, often around small blood vessels, and that's characteristic of a straining injury or a longitudinal injury to the nerve bundle as a whole. And it's that that's causing all the pain, causing the fistulae, and we know that 50 to 60% of women with pelvic floor disorders will have problems with straining on the toilet. The general population is 20 to 30%, but in this group, because of the injuries to their pelvic floors, they're much higher in incidence. And of course, we don't know what the cumulative lifetime incidence of this complication is. And clearly, if you've got to be able, if you're going to insert this sort of mesh, then you've got to be absolutely confident that the woman's not going to develop constipation at some stage in the future. Because if she does, she's exposed to these terrifying lifelong complications. This is just a word on the removal of the mesh. Here's the partial removal, which is designed to remove the cheese wire effect. So the clinicians know that what they're trying to do when they do a partial removal, because they're trying to release the urethra from this cheese wire of mesh. It's easier said than done. It's not an easy procedure. Whether the degree of fibrosis sustains the cheese wire is another matter, but clearly the non-yielding polypropylene mesh is in effect acting as a cheese wire in these circumstances. A complete excision aims to remove the entire length of the mesh. That's a much bigger procedure, much more technically difficult procedure. Whether it's helpful to a woman or not, it's not absolutely clear to me. What's worrisome is that the professional societies are still making significant statements without even mentioning the word neuropathic or cheese wire anywhere in them. And they're beginning to justify mesh in terms of patient choice and things like that. That's wholly inappropriate and needs to stop straight away. In this particular report, they spent the whole report talking about myofascial or fibromuscular pain, which was often treated ineffectively by physiotherapy. They also talked about autoimmune and foreign body reactions. The autoimmune conditions that go along with this disease, these problems are usually caused by straining on the toilet as well. And the whole report was complicated by grading of evidence and recommendations. And all the professional bodies associated with obstetrics and gynecology, the Royal College of Midwives, the National Institutes of Health and Clinical Excellence, all continue to grade evidence and bias the facts by this particular misperception of what evidence is. We don't see that at the Royal College of Physicians or the Royal College of Surgeons, but for many of the professional bodies, this is a terrible bias which undermines a great deal of their policies and guidelines. This puts the pelvic neuropathic pain into the context of at least 5 other pain syndromes that women suffer and are totally unacknowledged by gynecology, or their etiology is unacknowledged by gynecology. All result from injuries to pelvic nerves, but the great red herring in the room is that of the ectopic endometrium, because it's the endometriosis that has been said to be the source of a lot of neuropathic pain, and there's absolutely no evidence that it is. It's much more likely that these 3 sources of injuries to pelvic nerves are the source of the pain, and these are a red herring, deposits of ectopic endometrium, yet all the clinical attention is directed towards their treatment. Same for vulval pain. We've talked about the mesh pain syndromes, and then there's this other one where a rigid hysteroscope is put through an injured woman's cervix, and a minefield of neuromas are triggered by the rigid hysteroscope, causing terrible pain and discomfort, which neither the patient nor the clinician can understand. A very serious set of complications which have achieved some significant attention so far. Now, it turns out that having understood about the injuries to the nerves, it's clear that both the gynecological syndromes represented by this injury here on the right and the great obstetric syndromes all arise from injuries to pelvic autonomic nerves. And I'm not going to go into the details now, but all the Greek titles for gynecological and obstetric syndromes, such as preeclampsia, intrauterine growth retardation, dysmenorrhea, dyspareunia, placental abruption, things like that, all have their etiology in terms of injured nerves. And we've known about these since 1945, but we haven't been able to synthesize this argument. It needs a little bit more work to prove it, but I'll look forward to bringing that evidence forward as soon as we have it. And that should be able to clarify some part of these conditions. And most of them, all of these pelvic neuropathic syndromes have as one cause the intrapartum care. And there is a considerable crisis at the moment in intrapartum care for a variety of reasons. But it's affecting both the babies at the moment with these hideous rates of loss all around the country and brain damaged term babies. And there's no acknowledgement yet that there's any injuries to the women, but the same prolonged labors that produce the injured babies also produce significantly injured mothers. And the mothers can be injured at the front of the pelvis, causing stress incontinence and prolapse, at the side of the pelvis, causing all these pain syndromes, or at the back, causing the OASIS or obstetric anal sphincter injuries, all of which last for a lifetime. This is a normal pelvis. This is what happens if you have too big a baby delivered by forceps or the wrong way around, and this woman has her pelvis entirely wrecked, and she will be a candidate for surgery or present indications for gynecological surgery every 5 to 10 years for the rest of her life. The significant problem is that the labors are too prolonged. We're going through a patch of induction of labor, induction of nulliparous labor in particular, where the tissues become too friable, there's too much edema, there's too much opportunity for injury at the time of delivery, and any risk factor exposed that the woman's exposed at the time of delivery will tear her anatomy. And so there's an array of recommendations here with respect to what to do with labor wards. Most drive at obstetric traditions and midwifery policies, which have been all too out of kilter in recent years, leading to these epidemics of birth injury, and no consideration at all of neuroprotective intrapartum policies. So in this wider context, I've taken both of Baroness Cambridge's obstetrics and gynecology reports. I think that this is a much wider context I'm talking about now. I certainly agree with the initial recommendations. I would go stronger with respect to a ban on the vaginal mesh, because it's quite clear that the specialist interest groups are not understanding or don't want to understand the etiology of these complications. Clearly, there were other recommendations there that were there to improve the breach of trust and confidence that women have had in their clinical gynecologists throughout this episode. In addition to that, I'd commissioned some specific research over a very short period, over 3 months, to ensure that the expert evidence is in place to enable these effective redress actions, not just small redress actions, but really direct redress actions. So we look at the 20 vaginal walls to confirm that there's a neuropathic injury in the excised mesh. That's all stored in pathology units and is very easy to access. It would take no time at all to do that. And also to image these mesh retraction syndromes where a particular mesh may be shown to be defective by some precise imaging. Single team of solicitors at point of contact. Straightforward. Specialist centers for removal of mesh should be largely done by urologists. Clearly need to go back to copper suspension and avoid any vaginal mesh at all. with respect to the specific recommendations, it's clear that we've got far too many regulators and managers in the NHS, and that we need to avoid further such regulation. There needs to be an urgent review of intrapartum care for all these units that are coming out of the woodwork. There'll be another 20 yet where there's been unacceptable losses. And we've had a £37 million settlement this week for a 2013 case. And we're currently running at 750 brain damaged term babies per year in the labour wards, which is just wholly unacceptable. And then clearly there's this problem with the professional bodies where they omit, evade, or misinterpret evidence. And this is pervasive, unfortunately, in obstetrics and gynecology. It undermines all their guidelines and protocols, and it's vital that that's put straight at the earliest opportunity. But this temptation to omit and evade evidence so as to maintain the doctor in charge of the doctor-patient relationship in obstetrics and gynecology really has to be dealt with immediately, really, because it's that's enabling the Royal College of Obstetrics and Gynecology and the Royal College of Midwives to maintain the relationship where the doctor or the midwife is in charge of the relationship, rather than what's required in law at the moment, where the woman, the patient, is put in charge of the relationship. So in conclusion, we've got a wide range of pelvic mesh syndromes. They are from recognized causes. They're very common. They're caused by 300,000 nulliparous deliveries per year, 300,000 evacuations of the uterus, and 20 to 30% of the population straining on the toilet. Excuse me. The causes are clear. And they are entirely preventable. And absolutely critical that some degree of neuroprotection is put in place for women at the earliest opportunity. Now, in Shanghai, when I started inquiring about mesh disappeared in 2010, and I was politely asked to desist from making further inquiries. They'd seen enough mesh complications and had stopped using it completely. But in that unit, 16,000 deliveries, there was only a single urogynecologist, because there was no call for their services, because there was no incontinence and prolapse to deal with, because women weren't induced in their first labours. And if they went into spontaneous labour or they had a cesarean section, then the matter of injured nerves did not arise in the same way, and certainly not the injuries to the anterior part of the pelvis leading to urinary incontinence and genital prolapse. So that's my take on the wider spectrum. There's no criticism of the review team. They did their group, they did their job. They were looking at a wider argument than just vaginal mesh. They were doing primidos and valproate and all the rest of it. But I hope that fills in some of the gaps and explains some of the reasons why things are not as they should be in women's health. And they need to be put straight very quickly and promptly. I'm not sure that it's within the capacity of the professional bodies and the professional societies to do that. And it does need some external agency to do that. So that's all I want to say for today. Thank you very much for listening. I'm not going to say anything more about mesh because I think that's enough. But I do hope that fills in some gaps in the current argument.